I always find it really interesting that, so this topic I'm going to be teaching about is IV cannulation like a boss. And it's funny because it is probably one of the easiest things I do, but it is just one of those things that, you know, if you can't get that cannula in, it means that the list just doesn't go, the patient barely can have theatre surgery. It's just so impossible. And just everything to do with, you know, having a safe operation and resuscitation and, you know, getting effective medicine is all about cannulation. So it is funny that, you know, all the high-end stuff that I know probably doesn't, you know, it matters a lot, but without this really, you know, early technique that you learn as junior doctors, junior nurses, junior paramedics, or junior healthcare professionals, it is just one of those really, really important things. So this one, I'm going to try, literally, these are my objectives here. Actually, sorry, these are my resources, which I'm sure a lot of you know about. I've got that podcast for first part stuff, and a lot of these videos are on YouTube. This is the IV cannulation playlist, so feel free to check that out. And yeah, we'll pretty much all of the stuff that I talk about, the actual demonstrations, and a few live videos will be from there as well. So that's that. Okay, objective, really, I want to blow your mind because everything that I'm going to put here is literally everything I know about IV cannulation. So I'm really hoping that you get something out of this. And again, it's considered a basic technique, but I try to learn everything in some serious detail, and I'm hoping that they'll come across, in this presentation. So objectives. We're going to go through everything. I'm going to go through quite a few of these things because I want to get to the tricky scenarios so I can ask people stuff as well. So I'll ask people now and again, and feel, you know, if you don't know the answer, don't worry, just say whatever's on your mind, and it's a safe place, okay? So indications, complications that you can get, equipment and setup, identifying a vein, choosing a vein, cannula size, cannula grip, skin grip, step-by-step method, as well as a whole bunch of scenarios that you probably won't even imagine that this could come up. And I want you guys to know that now, because when it happens, I just want you to walk in there and go, yeah, this is easy. I've seen it before. I've seen this in a lecture. So first of all, indications. Hey, just to kick you guys off. Hey, Samir, when do you want to give get vascular access with an IV cannula?
Fluids, medications.
Beautiful. And why is it that we want to give medications IV instead of orally, do you reckon?
Some medications have different bioavailability, so they might not be very orally bioavailable compared to IV.
That is exactly right. When you bypass the liver, you just have all these advantages. So as you probably know, it's obvious, we give medications, we give fluid, we give blood products, and we might even go down to radiology and give contrast, and you'll be there and the radiologist is saying, hey, I really need a 20 gauge. They've just got a 22, and you're trying to find a 20 gauge in the cubital fossa. And it's just one of those things that you'll come up time and time again. But yeah, the advantages are absolutely right. When I give something IV, I don't have to go through the liver, so there's no first pass metabolism. So all of the drug that goes into my veins is going to go to the effect site pretty much. Whereas through the stomach or through anything that, you know, any kind of oral medication will have to go through a portal vein system, through the liver. It gets, you know, pretty much conjugated, and a whole bunch of other stuff happens with metabolism there, phase 1 and phase 2 metabolism, and then it goes around into circulation. So for example, morphine, it's only 30% bioavailable, whereas if you give it IV, it's fully bioavailable. Also faster onset. The other really important thing with anesthetics, I want my medications to act right away. I've got a short attention span. I need things to act straight away. And because it's fast onset and often fast offset, it means it's titratable. So you can run an infusion very easily to keep a plasma level very, very accurate. So those are some of the advantages. Now, what's the worst that can happen? Hey, I might just ask Jeff, what do you reckon, Jeff Sanderson? What's the worst that can happen when you put a drip in? What are the complications?
Well, I guess you could create an infection, probably not immediately.
Yep.
You could create trauma. Mm-hmm. It could not deliver what it needs to deliver, or it could deliver it outside of the IV.
Yeah. Actually, I really like that you got one of the reasons that I haven't even put in there. And the first thing you said was actually, you took my category straight away. You said late stuff. You said infection, that happens later, and you said immediate. So again, I'm going to teach you frameworks. Whenever you're asked, what are the complications? You say, well, there's immediate and late, and then you talk about those. And again, that makes you sound smarter to your bosses. So immediate stuff, really, and it's damage to structure. So trauma, exactly what you said, hematoma, nerves, arteries, there's pain, and a really rare thing, or not really rare, it's one of the more common anaphylactoid substances chlorhexidine. So, just make sure you check with your patients if they have a chlorhexidine allergy at all before you put the swab to clean the skin. If they had chlorhexidine anaphylaxis, something serious, I'd just use alcohol or betadine instead. So there's always that option. But yeah, those are all your problems that you could get, and late as well, infection. So it means that really your cannulas cannot stay for any longer than 72 hours. And often you're checking it every day, or some of the nurses are checking it every day and noting it down that it's absolutely okay before they decide to keep using it. And obviously, if you have a cannula in a patient and they abscond, or they get access to medications, they can misuse it as well. Now, the equipment. So this is, again, pretty straightforward. I've just put a list of stuff there. So you need a tourniquet, you need some kind of swab, alcohol chlorhexidine, maybe even betadine, a cannula itself, bung, tegaderm, dressing, saline with a 10 ml flush, and then you need a tray to just kind of keep it sterile in, a sharp spin, and gloves. And this stuff will be really obvious to you. I used to just line up all of this stuff on a tray and just go around in the ward when I had a whole bunch of cannulas that needed doing, and you'll get very familiar with that. Now, I'm not going to go through aseptic non-touch technique, but really you want to create these micro-sterile environments as best as you can. So you have a tray, but anytime you open something out, you just keep it in that sterile container until you're about to use it. So they call this general aseptic field with micro-sterile environments for the key parts. It's just something to know. And again, if you're going to do this in front of your bosses, try to do it this way, because this is kind of technically the right way of doing it. Good. Hey, by the way, if there's any questions at any point, please feel free to ask. I know this first few things are pretty straightforward. And identifying a vein. So look, there's so many ways we can go around doing this stuff. So I always think make it large, or and try to feel it. So does anyone want to volunteer how they try to make the vein large?
So you can like put the arm, to help with gravities, to put the arm down, as well as obviously putting on the tourniquet and sort of getting them to pump their fist as well.
Yep. And why does tourniquet make sense? You prevent the backflow. Why does pumping the wrist work?
I think it just increases that, just through the muscle activation, increases the venous return. So
Yeah,
you get more blood in there.
Absolutely. Increased metabolism means increased blood flow, which means increased blood circulation, which means increased venous return out of that capillary bed. Absolutely right. Look, and some of the other things. So tourniquet, absolutely. The right tourniquet pressure is above venous pressure and below arterial pressure. So if you want to get really specific, you put a blood pressure cuff on and dial it below your systolic blood pressure, and that means you'll get the absolute best conditions. I've got to say, I used to do that. I don't really need to do it now. I really haven't had a problem just using a tourniquet and going, yep, that's tight. The pulse is still present. Great. The patient's not complaining it's too tight. Fantastic. Increase metabolism by pumping the fist. And often what you see is patients do this. So I make sure the patient's hand is down, so it's not releasing it. So for example, it's pretty cold here in this theater, but if you can see my veins, it's far more prominent if I put the vein downwards, and you can just check that on yourselves. Gravity is really important. I keep it really low. I try to make it warm by making sure the environment is warm. So just don't use wet, warm cloth, because that will evaporate and dry and cool very quickly. So just cover the patient up with warm stuff, or say you've been requested to do it by the nurse. Before you go there, on the phone, you say, hey, could you wrap the patient up in some blankets, or get something warm, a hot water bottle or whatever it is. Just don't make the area wet. Now, same person, why does tapping the vein, why does that work? Yeah, look, it's just one of those things where if you tap the vein, it releases these vasoactive mediators. So the nitric oxide is probably the biggest one, that you release it from the endothelium, and it just causes, it attaches those receptors and then just causes this dilation of the vein. So that's why we do it. Now, there is also that thing, nice, cytokines, prostaglandins. There's a whole bunch of substances that do work, and I just remember nitric oxide, but I'm sure other ones do it as well. One of the interesting things is that you'll be taught many things, and I'm gonna try and just break a few myths and a few absolutes. Some people tell you, don't tap, that hurts. I've got to say, look, tapping lightly probably doesn't hurt, but if it does hurt, it only hurts in some people. So whatever I'm doing, I don't take any kind of gospel of it. It's not like it's always true. If it hurts for that patient, if you're tapping pretty aggressively and it does hurt, stop tapping. But there's really no right or wrong answer for this. Sometimes just rubbing the vein like that also helps. So yeah, release those vasoactive mediators. Now, this is really important. The feel should be bouncy. So, it should not be pulsatile. That's obviously an artery, and not firm. That's obviously a tendon. And, I would just encourage you on yourself, on your friends, at work, just really get used to feeling veins, because your ability to sense that that's a vein and that's not a tendon, and it's not a lipoma or some fatty tissue or muscle. It's a really important skill to be able to outline this. So that's really important. So that said, so there's, we've gone through the complications and how to identify a vein, but sometimes you'll identify a vein, but you know that there's going to be some regions that are greater risk. Does anyone have any concept of which areas of the body might be more risky for cannulation?
The brachial artery, the medial aspect of the cubital fossa.
Absolutely. Anywhere in the cubital fossa, danger zone. Perfect. And look, that's going to be the most common danger zone. I'm going to tell you stuff, tell you some other stuff as well. So besides areas that there's a lot of stuff going on, like any of the fossas, you're not going to be cannulating, generally speaking, in the popliteal fossa, you're behind the knee, or the axillary area, but that's got a whole bunch of other stuff as well. So whenever I do an anesthetic block there for like an axillary nerve block, I'm going to be so careful, because there's vessels, there's nerves, there's a whole bunch of things going on, and it's just really risky. The cubital fossa, I also do nerve blocks in that region. I've got to be really careful. So cubital fossa, absolutely, but also the cephalic vein near the lateral wrist, so kind of that anatomical snuff box area is a bit of a danger zone. So why I say this is you want to be aware of aberrant and superficial arteries. Now, here's a study that was done. So 4 patients with a clinically significant radial artery anomaly. So this one shows that the conventional radial artery just goes on that lateral side of the anterior wrist, and you can kind of feel that on yourself. That's where most people take a pulse. But then every now and again, you get this superficial radial artery that traverses really near where you might do the cephalic, like the cephalic vein puncture. And just know that happens often enough. And if you give anesthetic medications, especially, or antibiotics, or things that really hurt, that's going to be extremely painful for this poor patient. So just really remember that. I didn't hear about this until I did anesthetics. So hopefully you know that now, and it's it's useful for you. Okay. So how do I avoid this? Now, this is pretty simple. I check pulsatility. If it's pulsatile, you're in target country there. Let's say so one of those examples, let's say you do go for a cubital fossa and you go medially. So your vein is often overlying your brachial artery. Just know that if you were to feel that area, you'll get pulsatility, but you can see that there's a vein superficially. So let's say you go for it. If you get suddenly really fast backflow, and as you kind of take your needle out, you get pulsatile blood, that's obviously an artery. You got to take that out and put pressure for at least 5 minutes, unless you meant to do an outline. Sometimes you'll get that high pressure blood. Maybe you didn't notice pulsatility. Pulsatility isn't absolutely guaranteed, because your cannula might be up against something, and so it's just going to have reasonably bright blood coming back. Now, once you connect an IV line without a valve, so some IV lines just have no valves through them. If you connect one of those IV lines, you'll see this jet of blood going up. So that's a sure sign. Just know that that's not always going to happen, because some fluid lines have a valve that prevents backflow. So just know that fast backflow, high pressure, this is all an indication of arterial blood, bright red blood as well. Here's a little diagram from Moore's clinically oriented anatomy. And you can see that, like, let's say here medially, that's where can you see my arrow? Yep. So that's oftentimes you're going to go here. Sometimes there's going to be a vein across here, and often you'll see one just on that the lateral side as well, just up there. But this one here is where the artery is so superficial there. So this is the medial side. You've got this artery going there, and you've got this biceps tendon that can feel like an artery, and you've got a bunch of nerves right near the artery as well. Just know that your vein is so superficial that you've got to know how to avoid this. So that's where we're going to go. If you know the depth of your needle at every point, like you look at the needle insertion and you roughly outline how many millimeters till the hub, so you'll know roughly at any point where your needle is. What I mean by that, hopefully this makes a lot of sense. This is a 14 gauge needle, just to help you demonstrate at all points. I know that this is roughly, 4 centimeters. And so if I'm down to there and I've only got 3 centimeters left, I've got a centimeter in there. So really always have a really good idea of what your what your needle is looking like and what the distances are. So if you know the depth of your needle, just go really shallow, because you know that if you've got no flashback after about 5 millimeters, probably think again, or reinsert or reangulate. Especially when you're starting out, try not to go deeper than a centimeter in most situations, because your superficial veins aren't going to be deeper than a centimeter for sure. You should be able to get flashback within 5 millimeters. So choosing a vein like this is just one of those things. In an emergency, I will choose whatever I can get. I am not fussy at all. It's an emergency. I need to get fast acting, rapid acting drugs to the patient as soon as possible. That's a good question. So what do you think of using devices such as vein finders? I've got to be honest, I haven't used a vein finder ever in my life. But I know that some people for neonatal case use one of those torches, and that shows a shadow of a vein. I think that could be incredibly useful, but I've never used a vein finder. In emergency, whatever I can get, I also choose the most peripheral vein that suits the purposes of what I need to do. For example, if I've got one long vein on the forearm, I'm not going to go there initially. If there's suitability down there, I'm going to take that. If I do fail and that clots off and has a hematoma, I can still go maybe 5 centimeters proximal. If that fails, I can go 5 centimeters, just like that. So I always choose the most peripheral vein that I can fit the cannula size that I want to. Really, there's a whole bunch of logistical stuff after that. Maybe the patient is right-handed or left-handed. That's probably important. Overlying joints is kind of annoying, especially at the cubital fossa if it's not just a resus strip. A lot of the time if in resus, I don't care where I put it, arm, cubital fossa, across the wrist, doesn't matter. But then if I've got an elective patient who's going to be in bed, in hospital for a while, and they're going to be on a drip for a while, I really try to make it on the forearm area, because that doesn't limit their hand dexterity as well. But often it's going to be on the hand, but not overlying the knuckle in this area here. It's not going to be overlying the wrist, and maybe and hopefully the forearm, and not overlying the cubital fossa. There's nothing worse than when you're a patient and you kind of roll over in bed and you bend your arm, and then the infusion pump just beeps continuously and you've just lost sleep all night. So I really consider that important with my patients. Other little things like when you're doing surgery, the surgical side, for example, having the way my theater is oriented, I often put a left-handed drip in just because the anesthetic machine is on the right side. But sometimes, the surgeons want the left arm tucked in for lap appendectomies, for example. So it's kind of annoying not being able to see a drip. So often I'll then put the drip on the right side. Try to think about where the orientation is as it suits you. Obviously, patient preference and their knowledge of their own veins. Some people just have no veins on one side and great veins on another. And I always take that into account as well. Now, when should you always avoid a side or a vein? I might just ask someone randomly. Harrison Symes, what do you reckon? When would you always avoid a particular side?
If they've had a previous surgery on that, like a maybe like a lymph node dissection, or if they've had, or something that sort of impairs the ability of the.
That's great. That's exactly what I want you to mention, actually. Lymph node dissection, for example, anyone who had mastectomies on that side, you'd be really concerned about loss of lymph nodes. And so it really is just an infection risk. You don't want the lack of lymph drainage, therefore increased risk of infection there. If it was any other operation, probably it wouldn't matter. So for example, just a fracture there, maybe a lipoma excision, it really doesn't matter, but lymph node dissections definitely do matter. The other situation is, and I remember once being in theatre for a vascular list. The patient needed an arteriovenous fistula, and they had renal failure. They needed a fistula, and the really great intern was in there early and put a drip in the wrong vein. That was the vein they were going to use for the AVF. So if you've got an end-stage renal failure patient, really be careful about which veins you use. I would almost call the registrar and find out, if not the consultant, go, hey, are you going to be using this vein? Because it's so critical. Those veins are life to those patients. If they don't get that fistula, it means that they've got a peritoneal dialysis and they're waiting for a kidney. It's all pretty terrible. So really beware of those very specific circumstances. Again, I didn't learn until I started doing anesthetics or colleagues in vascular rotations. Obviously, infection is a kind of common thing. If there's an infection overlying that region, really stay away from that. And also pain syndromes. If someone's got some weird complex regional pain syndrome or something like that, that's a really tricky situation, and you definitely want to stay away from that. Now, choosing the cannula size, I'm going to just give you a few simple rules. So for most general situations, a 22 gauge is absolutely perfect, because if you're just giving medications at a low rate, and if you're, just putting fluids at an 8, 10, 12 hour, even a 6 hour rate, you don't need more than a 22 gauge. If you want to know what your flow of your cannula is, literally, definitely in these Intracan safety cannulas, if you look right there, hopefully you can see, you'll see 25 mils per minute. So, sorry, that's 35 mils per minute. And compare that to a 14 gauge. I didn't learn this until quite a few years as a doctor. That's like 350 mils per minute. Really useful to know what kind of the maximum average flow rates are. Is there a time limit on not using lymph dissection? I had mastectomy 20 years ago. Hey, that's a really good question. And I don't have an answer for that, I'm sorry. What I might do is I'll try to get an answer from one of my general and breast endocrine surgeon colleagues and find out, and then maybe send an email out. That's a really good question. So 22 gauge, absolutely perfect. Maintenance fluids, medications, in general, it's completely fine. If you had patient concerns for any reason, met calls, unstable vitals, that's like, I am a bit worried that this patient is going to deteriorate. I'm going to have to give drugs and fluid and other stuff rapidly. So I might err on the side of putting a bigger drip in. Now, 18 gauge is probably a good balance between, it's not crazy big, because you got to balance it up with the fact that if you try to put 14 gauges and you're just starting out, you're probably going to miss the 14 and 16 gauges. So an 18 gauge is a pretty good drip that will last most of the time, and it's got a really high flow rate. So when I think 100 mils per minute, that's a lot of fluid. Like the chance of you having a patient with blood loss greater than 100 mils a minute is really unlikely. So 18 gauge is a really good all-around resuscitation drip that you'll be able to get, even after being a beginner at IV cannulation. Are there any issues with implanted contraceptive devices? I've never been asked that question. So implanted meaning like the, I forget the name, but you've got the progesterone one that's like Implanon. Look, I would not go, often that's away from any veins. If the GP or the surgeon who's implanted has injected it near the skin, it's probably not going to be near a vein. It's very unlikely that they've chosen a site there. So it's going to be away from any vein. I'd say it's not something I've ever thought about, because veins are always far from that. Additionally, often, as far as I've seen, the implant in the arm is very rare for me to put a drip in the arm. So again, I wouldn't have any problem with using the same side, especially because I'm going to be putting a cannula quite distal to it, and it's not going to be anywhere near it anyway. Is a rash an absolute contraindication to cannulating a vein in that region? Look, I would say it's not an absolute not many of these things are absolute contraindications, but I would stay away from a rash in that region. There's a good chance that there's might be some level of infection there. If there was another vein, I would choose another vein. That said, if I had a patient who was deteriorating and I couldn't get any other drip in, and I've done this once in my career, I've just told the surgeon, look, that the drip on the other side is tissued. She has no veins because she's on chemotherapy, and I need to get the blood pressure up from 70 to something reasonable. I need to use that, and we'll just take it out and watch it, give antibiotics if you need. So I'd say that there's no absolute contraindications to anything, but I'd stay away from that. Is there a minimum size for IV contrast imaging studies? Yeah, so what I've been told in my experience, it's a 20 gauge, and sometimes that 20 gauge has to be in the cubital fossa. I suspect that things have changed based on the better resolution and better functioning of CT scans in general. So this may not be current, but generally a 20 gauge in the cubital fossa is what I've seen used. Always ask the radiographer at the time. Now, there are some situations where I'll really expect rapid blood loss, massive blood loss needing rapid, massive transfusion. And you really need to consider this as a very unique circumstance. Trauma cases, liver resections, AAA, abdominal aortic repair or thoracic aortic repair. I once had this patient, multiple dissections in multiple parts of the body. Literally, I was so worried that this patient was just going to bleed out in front of me. Fortunately, that didn't happen, and it all went really well. But I was ready. I had this patient with 2 big drips and a central line. One of them was a rickline, which I'll tell you about soon. Another was a 14 gauge. If anything happened, I had everything ready to go because I was anticipating the badness that could happen. So yeah, 16 gauges and 14 gauges, really great flow rates. The 16 gauge is 215 mils per minute. The 14 gauge was 350. So you can rapidly transfuse stuff with that. Now, the insider tip here is, do not worry if you can't get a 14 gauge or 16 gauge. And maybe, you know, you've just done 22 gauges. Maybe you've done only 20 cannulas, and you're there at a resus or at this horror situation, and you go, I can get a 20 gauge into that drip. You know, let's say it's a big muscular vein like the cephalic vein or somewhere in the cubital fossa. Generally speaking, the hand veins aren't as amenable, if they're not thick walled, to dilation, but you can put a 20 gauge in to a big vein, knowing that you can get it in, and that will be far better than blowing the vein, because then your senior comes in with their cape on and converts it into a 12 gauge rapid infusion catheter. So I would do this even now. If I thought I couldn't get the 14 gauge into a slightly smaller vein, I'd use a 20 gauge and then just dilate it up. Or if I was junior, this is exactly what I'd do. So let me tell you about that just to start with. So this is a rickline. So it kind of comes in a kit like this. And what it really is just a couple of pieces of equipment. So you've got, probably the first thing to know is you've got this thing here, which is a dilator with a cannula overlying it. So if I was to just pull this apart, that's just the safety kind of plastic. And I've got a dilator inbuilt. So often you don't always have the dilator in, like, central lines are separate. And so if I take the dilator out, you can see that it is coming out, and that's the thing that goes over the wire. So I'll just show the dilator coming out, and that's inbuilt. And what's left in the patient is this really massive cannula. What's left in the patient here, a really massive 12 gauge short cannula device called a RIC, a rapid infusion catheter. Yeah, beautiful. I'm going to talk about that. So what do you mean by converting a smaller IV into a large one? This is magic. I can't believe no one told me this when I was a junior, because this is the kind of stuff that saves lives. So literally, you got those three pieces of equipment. You insert the 20 gauge cannula into a decent sized vein or muscular vein. Often it'll be the cephalic here. Maybe it could be one of these ones, but often one in the cubital fossa as well. You get that 20 gauge cannula in. You then thread this wire in, which you can see on that diagram. You can see there as well. Like this, I can just take out with, you do as a sterile technique, you just take this thing out, the wire out, and that can just stay on your tray. You put the wire down that 20 gauge. I might as well demonstrate this. This is so useful. This is not something once you've seen one done, even juniors will be able to do this. It's a very easy to do, safe technique. Okay, let's actually do this. I'm not allowed to demonstrate this on the arm that I've got here in the background, but let's show you. So let's say I've got that cannula and that's in the patient. So the cannula is in the patient. I literally thread the wire. Now this wire is going to be inside the patient's thick vein. I take the cannula out. So I've got a wire going through the skin into the vein. The next thing I do is remove the 20 gauge, as I mentioned, cut the skin next to the wire. So imagine I've got, like, the wire is in through the skin. I make an incision just near where the wire is alongside the wire. So now I've got a bit more of a, I've got more of a cut that allows me to put the dilator and cannula in. So I'm going to put that safely away. The next thing I do, I take this dilator inbuilt with the cannula or rapid infusion catheter. The hardest thing is putting it on the end. I then put it on the end, and you'll find that all it needs is a bit of a push, and it will follow the wire into the vein. So that thing will now be in the vein, and all I've got to do is take the wire out and then take the dilator out, and that's going to stay in. Does anyone have any questions about that? I wouldn't say you do this straight away if you're junior. This is something that you'd get your consultant or registrar to supervise you with, but it's a very safe and relatively easy technique as long as that 20 gauge is already in the vein. I then suture it. You'll see that there's a little nib here, that thing that stays in. You'll put a suture line there just to make sure it doesn't fall out. And then you can collect fluid. This is a normal Lua lock connection. Connect any fluid to that and secure with a tegaderm. Just in the chat, Risk of perforating the vein. Yeah, look, there's always a risk of perforating the vein. With the wire insertion, there's very little risk of perforating the vein. That wire has a really soft tip. And this is not always the case. There's some wires, like central line wires, have a very hard tip, but they're curved around like this, which means that central line wires will only ever hit the wall like that, not like that. Okay, that's the central line wire, but this one has a very soft tip. Very soft tip. Hope you can see it there. Okay. Risk of perforating vein. The only time I've perforated a vein with this technique is when I used it on a very tiny vein on the hand that just didn't have the wall. Thick walled veins have more elastic substances or elastic collagen in it, so that is amenable to dilation. Whereas some of these small veins aren't. There are definitely some thicker walled veins in your hand that could be amenable to this, and I'd say those are the ones that dilate up when you tap on them. Yeah, my understanding of the dissection is that the bigger problem prior to sentinel node clearer was complete auxiliary clearance were the norm that left patients with lymphedema and difficulty managing otherwise minimal localization, which would otherwise be clear. Yeah, look, all I know is from what the surgeons I've worked with have told me, it's an infection risk and to stay away from it. The infection risk is probably low still, but it's just one of those standards. Again, nothing's absolute here. I just haven't seen enough of that or the problems with that. Wouldn't widening the cut with the blade be really painful for the patient? Absolutely. So, the thing I haven't mentioned at all here is I put lots of local around that area. So before I make the cut, I put local where I'm about to make the cut. So absolutely great point there. You know the thing is, often I'm doing this when the patient's already anesthetized. That's why I've forgotten to put that there. But you're absolutely right. Awake patient, definitely put local in. Is the cut transverse to the cannula? The cut is literally alongside the it's only a very tiny cut into the subcutaneous tissue, and it's alongside the wire. It doesn't really matter which angle it is, as long as it's alongside the wire, to just widen that hole slightly to allow this thing to get through without the skin tightening up around it. Can it be with other gauges? 20 gauge is probably the minimum size that this fits down, but you know what? I have got a cannula here that we could figure it out on. It gets caught on a 22 gauge. So 20 gauge is the minimum size we could use. That was easy. Can you cannulate a vein from the opposite direction to traditional cannulation? That is, can you cannulate proximal to distally? For example, an oblique vein, which only has one angle available. Not, generally speaking, not for, so the only time I would cannulate backwards, if you watch my video on reverse cannula for taking blood, that's the one time I do really difficult blood taking, I'd go reverse cannula. But if you do it for fluid administration, it's kind of going against the grain of things. Again, I don't think there's absolutes. People would look at it a bit strange and probably not use it. If I could get a cannula in, if I can get a cannula in backwards, I can definitely get it in the correct way. The only reason I use a reverse cannula is for blood taking, because if you're taking blood, it allows you to receive the blood from the direction that blood naturally flows. That's the only thing I can think of there. We're going to go straight now to doing this bit of this demonstration. Okay, so for cannula grip, I think it's really important that you get this right from the start. I know there's lots of people who can do really good cannulation, are doing multiple different grips, but I would really, really employ you to start with this technique, and there's many good reasons why. So the way I know my grip is correct is that the cannula is the lower structure. The thumb and middle finger is the one I use, right like that. And the pointer is ready to thread the cannula. Now, the reason I think this is all really important, well, I mean, first of all, the way I make sure I got it right is I lay it down. Let's say I lay it down on a stable surface, and as I pick it up, that's the way the cannula should sit. So it's not like this, because then my palm is in the way, and I might not be able to get a low angle depending on where the vein is. And it's definitely not like that, which I see some people doing, which is how we do use an art. That's how we do an art line. And then the other thing that you can see here is my pointer finger is out of the way. It's not overlying that, because I want to be able to see the blood flashback in the chamber. If my finger's there, it's in the way. Once I get flashback, however, I can then thread the cannula like that. And as you can see that I'm not moving any of my other fingers to do that. Like literally that's the only moving part. So in a very difficult cannula, like a big vein or a very small vein, a big cannula in a vein or a very, very small vein, then this is, I've got nothing else moving. There's very low likelihood of me traumatizing a vein. And then, changeable visible, as I mentioned. So that's the reason why I always cannulate with that grip, and it never changes from that grip. Now, in terms of the skin grip, there's all these, there's so many different ways that this can happen. So the first thing is, if I'm, doing a hand cannulation, my thumb is here, so it's definitely not on the dorsum of the hand. It's over the knuckle ridge there. And that means that as I'm cannulating, I can really flatten out easily, just like that. Like there's no problem. There's just no problem with me getting a low angle. And the low angle is what I need to make sure that I don't puncture the deep surface of the vein. If my finger was here, I couldn't get that low angle because my thumb's in the way. This does get trickier on the forearm, right? So, if I've got a forearm vein that I'm going for, often you'll try to put tension along the axis of the vein, but I've got no knuckle ridge to go over. So what I do then is I just put tension on the skin to the side. So that's just not a problem if I put it to the side, because when I'm putting tension on the skin, it's not to stop the vein rolling. It's just to anchor the skin to make sure your needle goes in really smoothly. So that's why if the vein is there, I just put my finger to the side and stretch and then go in. I've got no problems with my finger getting in the way. Same with the cubital fossa. It's not having any problems overlying that. So it's to tether or anchor the skin, not the vein, and it's to keep out of the way to enable a low angulation. So while we're here, let's do the step-by-step method. Now, obviously I'll put on gloves and I'll sterilize the region, but I thought I'd just demonstrate the technique rather for the purposes of this. So can we see that all right? As always, I put a tourniquet on, make sure I'm comfortable. It's probably the least comfortable I've ever been doing a cannula because I'm using an arm on a really weird trolley here. So the first thing I do after sterilizing the area, washing my hands, making sure I've got gloves on, I palpate, and these are amazingly good veins. Now, so I'll demonstrate on this arm vein just because it's nice and large. Hopefully you guys can see that angle. If I do have to tap again, I just re-sterilize it with chlorhexidine alcohol swab. Now, so right now, as you can see, I'm doing a few things. My tension on my skin is within my thumb here. It's out of the way. I've got my grip, which is thumb and middle finger. My pointer finger is out of the way. And I've got these fingers here just anchoring everything to make sure that, it's, just stabilizing my hand. If I had my hand up in the air there, it'd be really wobbly, right? So I've got a bit of a flashback there. Hopefully you can see it. I level out a lot just to try and make sure I don't cut the bottom surface. I go in about 4 millimeters, and then without changing anything, I just thread this through. Now, the interesting thing about that is the skin's really hard on these kind of latex type mannequins. But yeah, you should be able to thread that really easily in most skin. I then take the tourniquet off, put my finger up there, take this away, and then put the IV bung on. I'm just going to take that away so it stops dripping. And that's pretty much cannulation. Now, obviously, I'm going to have proper, I feel like cannulations on arms are just so limited because it's just not really like real life. And you'd use this mainly to get your actions, like the order of the way you do things nice and stable and familiar. That's really the main reasons why I'd use the mannequin for any purposes at all. But just know that it's, you just really have to practice on patients, and that's the best way to do this and get better. Do you flatten out as soon as you get flashback, or do you advance on an angle slightly then flatten out? It's a great question. So as soon as I get flashback, I absolutely then flatten out because I don't want to go any further into the, at a sharp angle. And I've done so this demonstration, one of my favorite demonstrations. It's something that someone showed me back in the day, and it really changed the way I thought about cannulation from that point on. let's use this one. In this demonstration, you know, the design of this cannula is amazing, right? So this cannula has a really great cutting surface at the tip and a very flat, very blunt top surface. Say you've got a really tiny vein. This is if this is a vein, this is obviously a massive vein, but it will be good for demonstrating. It is really good at cutting into the vein and also cutting the deep surface of the vein. Can you just see that poking through? Really easy to do that, right? So as soon as I get flashback, I know that I'm in. I lift up, so I'm leveling off and lifting up because it's really hard to cut the top surface of the vein. So just to put that demonstration, it's really easy to go through and cut the bottom surface just like that, but it's really hard to cut the top surface. So as soon as I got flashback, that means that I'm in the vein. I level out because I don't want to go anywhere near that deep surface. When solo, how do you manage keeping pressure above the vein whilst putting the bung on? Hey, you know, I didn't demonstrate that, so it is there's a bit of an art to it. The first thing is don't worry too much. If the patient loses a couple of drops of blood, it is better that you got that vein in, that cannula in the vein, rather than worrying too much about not making absolutely any mess, because that will come with a bit of diligence. Now, the way I do it, this is literally what it looks like. So I've got the bung and I flick off the top bit just like so. And then, so let's say I'm not holding that vein, right? I'm just putting pressure on the skin. So this is flimsy, right? So what I do, because I don't get too much traction on it, I jiggle it in like that. And once it's kind of latched on, then it's not going to backflow too much. Then I hold the cannula and then I screw it on. So all I'm doing is getting this just on there and jiggling it. As you can see, that makes sense. But, you know, that's not on at all. And then I tighten it. I'll just do that demonstration here as well. So if I'm putting pressure distally, this one isn't stable. It's very flimsy. I just do that and jiggle the bung on. It's not tight at all. And then I transfer to here and then I do it. So while it's capped on loosely, there's going to be no blood flow back. It'll be absolutely fine. That said, I just have to put a bit of gauze there. If you needed this, put a bit of gauze and it just won't be a problem at all. That's a really good question. For blood taking and butterfly needles, would you advise a different grip to the thumb middle finger? You know, so anytime I get called to take blood, it's always because, you know, the blood taking nurses are amazing, right? So if they've missed, you know, I used to think as a junior doctor, what am I really going to be doing that they can't do? But what I realized was the one skill I have that they haven't trained at is using cannulas. So in the most difficult veins and most difficult patients, I just use cannulas for every single thing, whether it's blood taking or not, because I mean, it's obvious, right? So if I've got a needle in the vein and I'm extracting and trying to play that game of teasing blood out of a vein, first of all, that's causing a lot of movement, the veins collapsing, then expanding, collapsing, expanding. That could easily traumatize the vein. That's difficult. But if I put a cannula, which is a plastic tube straight in, I can take all the time I need. I could jiggle that around as much as I need. It's just not a problem. So I cannulate everyone for blood because I just think it's easier. If you haven't learned cannulation, it's harder. But if you've learned cannulation, which you all will, it's so much easier taking blood. Would you ever apply topical anesthetic? Yes. Patients who are needle phobic, you know, you can definitely try to do that. Some hospitals aren't set up for that. Every now and again, I get told a patient's needle phobic and they get in early enough, you can put angel cream or emla cream on. It's really effective. Often it's psychological though. So even though you've done that, they're still really terrified. And then I might give them a bit of nitrous even, if it's really a problem. Generally speaking, most pediatric cases that come down always have emla cream already applied. And that's really great because kids are often amenable to distraction. So you just distract them with something else, put a towel up or a book in front of them, where's Wally? And then you just put a cannula and they can barely feel it. They're distracted. Also kids, once you've done an inhalational induction, having the emla on means that maybe they're a bit light. If you try to cause pain to a light kid under anesthesia, if they're light under anesthesia during the induction phase, they could laryngospasm. So having the emla there is just an extra bit of security. In the hospitals I've been placed at, J-loops are used more frequently than just bungs. Is there much difference in benefit between them? Yeah, I don't see any real difference. I think it's really useful for not having kinks But placing them on, I just haven't done too much recently. I'd say it's just the same thing. If you lose a bit of blood, don't worry too much. You'll figure out a way to sort it out. You're all pretty intelligent, so I wouldn't be too fast. But what I do like about it is, there's one of those things that, and hopefully the stuff I'll teach you is not just the technical side of things. Like, I guarantee no one's giving you this level of detail for an IV cannulation talk. So if one of the really important things about getting on with everyone in the workplace is if you make a mess, you clean it up, or you just don't make the mess. So I'll always have some kind of towel underneath when I'm starting out. And if I do happen to make a mess, which happens every now and again, I just make sure I clean it up, change the bed sheet, change the whatever thing that I've caused a mess on. So that would be more important to me than whether I'm doing this correctly at the start. Hey, keep asking these questions. They're really, really great. Scenarios. Your mate attempts a cannula and fails, saying it was due to vasospasm. I can't see everyone's faces here, but true or false? The answer is false, because vasospasm just isn't a reason to miss. If the vessel spasms and you miss and you just don't even get a flashback, that means that you've still got another go at it. The vessel hasn't blown. That vein is still there to be accessed. If, for example, someone says a vasospasm as you're threading the cannula, that's kind of a cop-out as well, in my opinion, because if you're in the vein, there's no reason you miss. Aim up, advance the perfect amount, and thread of the cannula. It doesn't really, the vessel doesn't vasospasm over something in that way. It's just not a thing. I've done lots and lots of ultrasound cannulations, and I guarantee you that's never happened. You made attempts to cannula and failed, saying it rolled away. Again, not a problem. As long as you didn't breach the vessel surface, that cannula is still ready for another go. Take the needle out. If your hospital requires you to replace the needle, fantastic. Let's do that. Re-sterilize, go again, and maybe in a different position from before to where it rolled to. Try to get right on top of that. What I do know is that in certain patients, certain vessels definitely roll a lot, and you just have to get better at getting into that. There's times I've gone in, the vessel's rolled, and I've just re-angled the needle. And that's tricky, because once you get in, you got to change the angle again to make sure it's in the trajectory of the vein. You made attempts to cannula and failed, saying it's due to a valve. Again, absolutely false. The valve is an internal structure. And if you look at B, there's a definite reason why it's not going to flow, but all you got to do is either, what I do, I don't try to push it through the valve. That's kind of a tricky thing to do. I just withdraw it a little bit, withdraw it a few millimeters, make sure you can flush it, and then just tape it and tegaderm it, and that's it. If there's a bit of cannula sticking out, just tell the nurses and tell the other people looking after the cannula, don't worry, it's in, we need this cannula, it's flushing well, and just check on it every day. On the topic of taking bloods, routine bloods, not cultures, is it appropriate to use an established cannula rather than doing a fresh tab, particularly? Yeah, so it depends on if it's blood cultures, you definitely have to do a fresh needle for that and make sure it's the appropriate sterile technique that's required. I know that in some hospitals, it's not done where you take blood from existing cannula. I would say, logically thinking about this, and again, you can't rely on my advice because a hospital will dictate what you do. If a patient had a drip flowing with solution, with saline, with compound sodium lactate, Hartmann's, if I took blood from that sample, there's a good chance that the blood in that vicinity is going to be diluted and have a very odd electrolyte profile or hemoglobin dilution. So that's a problem. If it was a needle, if it was a cannula that was just sitting there for a while and no one had accessed it, if I just wanted your normal blood panel, I would take off 10 mils and then discard that and take off the appropriate amount. And then I can't imagine why that would go wrong. It's something I've definitely done. Like, for example, I've done that when I've had drips in for surgery, and I just repeat sample from that drip that's not meant for IV fluids. How do you tell where a valve is? Yeah, sometimes you don't know, but you'll see a bulbous kind of pouching, like an aneurysm type thing, and you'll get a sense for this. Over time, you'll notice that for some reason cannula just doesn't go past, and that will be a site where you have a little kind of outpouching on the vein. It's obvious to see in very skinny people with less subcutaneous fat. There's a thing you can do where you put a tourniquet on yourself and then you push the blood away, and you can see where the blood fills up to, that's the point of a valve. And so I've got this nice cephalic here. So I put a tourniquet on and I push the blood away from that while keeping the downstream pressure on the vein, so no blood is coming back, and no blood fills up until there's a valve and an intersection. So that's just one of the interesting things that you can probably look on yourself. But again, play around with, look at your own veins. You'll learn a lot about other people's veins in general just by looking at your own. How long after stopping the drip would you expect the blood composition to normalize? I don't have a really firm answer on that, but I would imagine if you gave it, probably a few minutes is all you need. But let's say you gave it 15 minutes, I think you'd be very safe. As long as the patient has a good going circulation, I'm sure 15 minutes is plenty. That's probably a good study to do. If anyone wants to do that study, let's make this happen. That whole section was really about, there's only 3 ways to fail a cannula. So this is from one of my videos where I do some really average whiteboard drawings. But first one's missing the vein completely. Doesn't mean you fail, you just got to get that vein again. So just re-access it in the appropriate way. Second is puncturing a deep or a side wall. That's a complete fail. So I don't believe in salvaging a vessel once you've had a go at threading. If you failed it once, then just leave it. You can't risk putting medications and fluids into a vein that might have more than a couple of holes in it. And insufficient advancement. So, you've got the flashback and then you don't advance enough and you're trying to push the cannula off and the cannula is pushing off and pushing the vein away. So these are really the only 3 ways you fail this vein. So what is really important to me, I honestly don't care if my junior doctors or anyone fails a vein when they're learning. I just really want them to know why they failed the vein. So I don't want them to say vasospasm. It wasn't a valve. It was either I missed the vein, I think I punctured a deep wall, or I didn't advance it far enough. If you know that that's the issue, you will get better very rapidly. But if you don't know that that's your issue, then it's a long day. So how far do you advance after flashback? Yeah, so really the answer to this is the bevel distance plus the vein wall. So thicker veins like the cephalic ones and the cubital ones, the big veins, that they might be at least 1 or 2 millimeters, and then a bit to account for where the cannula starts. So what does that mean? When you look at each of your cannulas, 22 gauge needle has like a 2 millimeter bevel. So it's about 4 millimeter advancement. 20 gauge, 5 millimeters, 18, these are just rough guides, 6 millimeters, 16, 8 millimeters, and 14 gauge, I'd probably advance it over 1 centimeter before I thread the cannula. So flashback, level out, advance over 1 centimeter, trying to aim upwards, which is counterintuitive, then advance your cannula. That it sounds so counterintuitive, but just trust me that you'll fail the large ones more so because you didn't advance the cannula far enough. That was my experience. Now, when should I use lignocaine? Yeah, so this is a hero moment. When you get called to do a cannula and everyone's missed and they've had 5 goes at it, you start with local and you get it in and the patient doesn't feel a thing. You will feel good. They talk about motivation. Actually, just being action and success makes you feel great and you just get motivated. So if you keep doing this, you will get very good at your cannulas because you'll have so many hero moments. So yeah, as a general rule, any large cannula greater than 18, I'd always put local in. If the patient reports considerable pain, if they've had multiple attempts, absolutely. And again, check chlorhex allergy. Check lignocaine allergies is what I meant to say there. Again, I've got a video on that playlist, how to put local anesthetic in. Again, really easy technique. I go over the vein, and that's always risky. You've got to be really steady with your hand. As soon as you get into that subcut tissue, that's when you start injecting, and that's barely a millimeter, okay? So, there's always the risk you'll rupture if you go low. And to be honest, I've ruptured a vein once in 15 years doing this. So if you've got a steady hand and you know to go very, just in the surface. So how do I know that I'm doing that? I actually lose a bit of local. So I'm injecting local even before I'm in. So as soon as I'm in, then I can see that blanching happen and then I know to stop. I'm also anchoring my hand and making sure everything is just lined up perfectly as well. So literally what I do, again, it's in the video, so have a look, but 1 to 2% lignocaine is fine. You don't need a big strength. It's such a small nerve fibers require no time and very little percentage to anesthetize. 3 ml syringe or a small syringe. You can also use 25, 27, 30 gauge needles are all fine, but the smaller the better. If I've got a 30 gauge, I'll definitely use that. And the pre-needled insulin needles, which are 27 gauge. These are fantastic. They're already pre-made. I just draw it up in the insulin syringe and then inject as I need to. Approach shallow, just into the skin. As you can see, that's a really shallow angle. And again, the dose is very small. I put there 0.1 to 0.2 mils, but really, I don't think I'm even putting 0.1 mil in the skin. That amount there that you can see blanching is less than 0.1 mils. And that's all you need. And it's instant analgesia. You don't have to wait. When I've had full flashback and advanced with secondary flash, have I gone through the vein and that's what is causing the site to bleb on. Full flashback. So flashback in the chamber. I'll just use this for demonstration. I've got flashback in the chamber. Then I level out, then I advance the whole thing, the appropriate number of millimeters. Then I advance the cannula. You'll get secondary flashback in the cannula. Again, I show that in a few of my videos. That means that you're in the vein. It's very unlikely that you're not in the vein if you've got the secondary flashback. So you haven't gone through the other side of the vein. And that's what is causing the site to bleb on flushing. There's something else going on. If you've got those two flashbacks, you're probably in and it had a smooth passage. Maybe there's another reason why the vein was traumatized, but you shouldn't get a bleb on flushing. Now, with the really large cannulas, there's 14 gauges, there's so much trauma with that big 7mm bevel that you can have a bit of a bleb in that region just from the trauma and the clotting factors and a bit of inflammation occurring there. But your 14 gauge is generally in. I'd check my video on how to know the cannula is in. And that's just a whole bunch of steps. But one of them you can do is a pulse test. You get a syringe and you pulse into the cannula and just check proximally to make sure that that you can feel that pressure wave, that you can feel the pulse happening proximally to where your vein, to the vein, where your cannula is in the vein. What to do about the difficult cannula? Yeah, so when I think about the difficult patients, these are previous multiple attempts, ultrasound was used, edematous patients, chemotherapy, obesity, age, older age generally, or even super young age, like less than 2 years of age, like 1 to 2 years of age, kids are really difficult cannulate. They've got so much fatty tissue on board. Dark skinned people as well can be difficult, repeated hospitalizations. Chemo is one of the worst, really. Like they have such tiny, fragile veins. Now, you're going to get a whole bunch of absolutes from people. And again, I'm just not that person to tell you absolutes. In the worst case scenarios and in short cases, I'll put cannulas in the feet, the wrists. This may not be appropriate for the ward, but just know that in theater context, for short cases, when you've got nothing else to go with, you're not going to put a central line in, you're not going to put intraosseous. We just go for those sites. And maybe on the ward in an emergency, you just need vascular access, and maybe you're not capable or comfortable doing the intraosseous needles and cannulas into the neck, wrist, and feet. If you need to, they're absolutely appropriate. Okay, there'll be some situations that you can't, and these are very just very rare situations. Like maybe you've got some kind of vascular rupture or some kind of weird fracture in a lower limb. Maybe you've got some mediastinal mass and you can't use certain sides. But these are all really weird and wonderful situations. So the referral you must do early on in these difficult patients. When you're starting out, you're not going to be able to get these cannulas straight away, and that's okay. But make sure you order a PICC line straight away. The cannula lasts for 3 days max. That difficult IV patient is going to be there for 2 weeks on flucloxacillin for some kind of heart valve endocarditis. Get that PICC line referral, and it'll make your time and everyone's time and the patient's time much more pleasant. How long does the cannula last? We've gone through that already, which is 72 hours max. You document it, put a sticker on there as well. Make sure that everyone knows how long it's been in, especially the patient. If there's any swelling, redness, pus, anything, you remove that cannula, report it, and get your registrar, get your boss to decide what to do about that, antibiotics or not. Now, next one, you're called to resite a cannula that's tissued. So I used to always kind of love going up to these because they were never really tissued half the time. What do? Look, I don't remove it. I make sure that on the phone, I say, please don't remove it. I'll come and check it because getting another cannula in is much more difficult. So first thing is I attend to the patient, I remove the dressing and check that there's, like even just today, I had a patient who had a ward drip come down and there's a little bit of air under the tegaderm, which meant that the drip could move around a bit and it kinked off. So now it was at a right angle and it just wasn't flowing. So remove the dressing, check for kinking of the cannula. It is so easy for this to happen, like especially once like this kind of thing happens all the time, especially after a bit of time. This kinking thing happens. Just redress, straighten it out, make sure that the adhesive is right there. The next thing I do is I get a 3 ml syringe and I flush. That 3 ml syringe is enough pressure that I can open up a tiny little clot. And that's pretty safe to do. The clot gets broken down very quickly by the body. It's not a big clot. It's not like a DVT type thing. It's just a little bit of clot in the cannula probably, and I'm just making sure that it's flushed all right. If I try to do a 10 ml syringe, it may not work. I can't generate enough pressure with a larger syringe. 3 ml syringe, 1 ml syringe, easy to flush. I then do the pulse test as well, make sure that I've got flow of that pressure wave up proximally on the vein. And obviously check signs of failure, swelling, pain, and anything else that might indicate that it's tissued. Okay, another question. When should you use an ultrasound for cannulation? Have you done a video on this? Yeah, I've got a video on that. So definitely refer to that video. If there's one technique that I'd tell everyone to get used to after you've mastered and have a pretty good strike rate at your cannulas, just start ultrasounding. It will, especially if you want to do anesthetics, your skill with ultrasound will just make your life so much easier for vascular access, arterial lines, central lines, as well as regional blocks. I felt that when I was training, they just started to have point of care ultrasound. So I was like, I'm gonna learn this. And it will make you feel really good because not everyone is able to do it. If you've just started, if everyone, even your bosses, have started learning at the same time, you'll be pretty surprised at how good you can get with a bit of practice. Okay, this scenario happened to me a couple of times. Diabetic patient, call from ECHO, unconscious. It's probably hypoglycemia, right? So that's the first thing you have to rule out amongst all the other altered conscious state pathology. And what do you do? What do you give? I might just ask someone quickly, what would you give this patient? Good. And in the research trials, they often have 50%, but yeah, if you give some kind of glucose, let's say this patient is unconscious, that means their glucose levels are probably less than 1, which is terrible. And so, let's say, one of your staff members draws up 50 mils of 50% glucose in that 50 ml syringe, but you can't put it through the 20 gauge cannula. Now, what do you do? It's not because the cannula is tissued. Just know that the larger the cannula, the less pressure you're able to exert, plus glucose is really viscous. So just remember that, because, literally, I had my assistant trying to push it in going, sorry, patient's unconscious, I can't do it, the drip's tissued. And because that's like my first part, I was like, I know what pressure is. So I just drew it up into 5 ml syringes or 10 ml syringes and just gave it like that, just gave repeated doses of that. Literally, this will happen to you one day. And, maybe the 10% will be fine. Maybe the 5% will be fine. But generally speaking, it's hard to find those on a resus cart. It's always 50% or 5%, and 5% might not be enough initially. So yeah, for the win, withdraw glucose into smaller syringes to administer. Hope this is okay, the pace I'm going at. Just want to get as much info out there. Okay, 60-year-old day 1 post-op lap anterior section. The blood pressure is low, it's 80. So pretty bad, it's on the ward, and the IVS tissued, and the patient has very difficult vascular access. Obviously, that's what we're talking about here. What do you do? So, I mean, this is really, obviously you call for help. Let's say the Met call and anesthetics team are far away, and maybe they're in another hospital and you're a peripheral hospital. So you can at least get some stuff ready for them, but you could try all the other zones, wrist, feet, arm, intraosseous, even watch a video on it. Like literally, there's so many good videos on intraosseous. As long as you've got that in the crash cart, I'm sure that you'll be able to do it with a bit of instruction. Now, let's say the blood pressure is now 60 on 20. This is peri-arrest. So what do you do? Now, this is something I'm hoping you really take away. You can temporize with other measures, even if you don't have vascular access. So literally the legs up. So this is what I've done in theater when I've lost vascular access. Get the technician to put the legs up, literally just lift them up, and all of that venous return goes back centrally and gives you a bit of temporization while someone is sorting out something else. So in my hands, I think a pretty safe thing for you to do, again, check, hopefully you've got someone supervising you on the phone at least, but ephedrine 15 to 30 milligrams IM, I'd definitely give 30 milligrams if I didn't have IV access for a blood pressure of 60 in most people in like the anesthetic context, but that will at least get you somewhere. And if you're really peri-arrest, just remember you can give adrenaline IM as well. And don't forget, if you need to do CPR because a patient is arrested, make sure you do that to get the blood going around, because without a blood pressure, without blood circulating, that's not going to go anywhere. So that's, again, a really uncommon scenario you're going to get, but I'm hoping that one day, if it does happen, you'll think back to this lecture and go, hey, I tried everything, and then I got the legs up, and then while I was waiting 15 minutes for the next person to come in and help me, I gave these medications, and that saved the day. How many attempts should I have? So look, there's a lot of people will tell you different things. I reckon 2 is reasonable, unless the patient is experiencing really, great distress. It's a known difficult cannula. It's really urgent, so you need to get it done quickly, and you don't want to be waiting if you're just having no luck at it. And sometimes you can have a patient with just one good vein available, and you don't want to waste that one if you're not confident on it, and probably save it for the anaesthetist. When you're making the referral, just mention these things. Look, I could have a go, but there's only one vein that I can see, and this patient is known to be difficult. So plead your case, because no one's ever happy when you refer them stuff. But these are the cases that I would plead. Hey guys, that's wow. I feel like we got through a lot there. Sorry it wasn't as interactive. Did anyone have any questions? And I really appreciate all your questions in the chat. There's such good questions. Any tips on getting the tegaderm, the skin dressing flush with the skin without tenting? I haven't. I feel like I haven't had that problem. What I'd say is, like, because the whole surface is sticky, I just stick it right down. And the problem I've had sometimes is that the patient's kind of sweaty, and what I do then is I just dry it off with gauze or whatever it is. What else would I do? You can, if you have real problems with it sticking, sometimes you can put Tink Bends, and that's just a nice sticky solution that's also antiseptic that you can put there. I haven't had to do that though. Yeah, I haven't had problems. I'd say if it's not flush with the skin, it's probably because of some kind of moisture or sweating. Just take it off and apply another one. Dry and apply another one. Do you have a way of securing an IV in patients with dementia? Fantastic question. So the nurses are fantastic at this in my hospital. First of all, you get the cannula in, and then you just wrap it round and round with a lot of gauze. Same thing we do for kids. So it's very hard for people to take that off. Also, to avoid having to restrain people physically or chemically, you can put mitts on some demented patients, so they actually they don't have the manual dexterity. So if you take away their manual dexterity, I know it sounds horrible, but that's what we've had to do in certain patients who we just need to keep them safe, keep the IV in whilst we're managing and sorting out their problems. So yeah, wrap it up with lots of gauze and have one point just coming out so you can still access it pretty easily. Otherwise, mitts are really useful. Great. Before everyone goes away, and then we went through these scenarios, hopefully lots of useful stuff: vasopressin, vein rolling away, valves, 3 ways to fail, cannula advancement, lignocaine, difficult cannula, tissued cannulas, glucose bicannula, and loss of IV and hypotension, and the number of attempts you should have. How do you cannulate a patient that might be having a seizure or thrashing? Yeah, that's a really good question. First of all, it's a whole thing. So if I wasn't to go through all the thing of safety of the patient, safety of staff, calling help, all of that, literally what I'd do is have 5 staff members and 5-point fixation as one of my techniques. Generally speaking, though, the seizure will settle down. So that's one thing. IM midazolam or whatever drug that your team gives, that will settle the seizure down. So let's go for the patient who's thrashing about and you just need a cannula. First of all, patient safety, staff safety. You're doing this for the patient safety. So I'd call security. This is not your thing to do. Security is trained in restraining that. So 5 security guards, 1 head, 1 for each of the limbs. That will keep the patient very still for you, and it'll still be difficult to cannulate. So you'd get your best team member on that. When you have enough experience and you have other senior staff around, you might want to give a chemical sedation as well. And often they talk about giving droperidol or ketamine or midazolam or something like that. Again, that's really advanced stuff, and there's so many ways that goes wrong. But yeah, droperidol at the right dose, as long as they don't have some kind of prolonged QT syndrome or it doesn't cause severe hypotension, that can be a really good stable thing to stabilize someone who's thrashing about. But physically, 5-point fixation and then give it your best shot is what I've done in the past. Really great question. It's funny, some of these scenarios are the things that I give my final exam, especially senior anesthetic trainees about to do the specialist exam. Like, this stuff is still relevant, and it's very difficult in the most difficult situations. And that's about time. Thanks for all the appreciation. Yeah, see you all next time.